So we are doing just purely Mentimeter today, and we will learn as we go. So all the Q&A that I have done today, it's a collective experience and question from our junior colleagues throughout my registrar experience. So let's start. I want you to join the discussion. Oh, is it not moving? Why is it not moving? Is it moving for you?
Yeah, it is. Let's
Right.
start. Yeah,
Yeah. And if everybody is ready, we will start. We're good to go, I guess, Joseph. Yeah.
yeah.
Yeah. So before I start, I want to know how many of you have worked on the renal ward before so that we have an idea of who has been. Right. Why can't I see the number properly? I must be missing some. Oh, yeah, there is 12. So I'm assuming that majority of you guys have not worked on the renal ward. So I think that would be okay. We have more or less like a more of a very junior colleague friendly questions on the ward. Right, let's start. And so if you've been there, how was the experience? So in general, you can add on about your experience or discussion with the renal registrar. Are we too grumpy or are we just friendly on the on the phone call?
Feel free to be honest.
Yeah. We are known to be OCD with the numbers, so that is a quality you need to be a renal registrar. Okay, not too bad, not too bad. Okay, that's a good start. Right. So from the score of 1 to 10, I would like to know as a junior colleague, you don't have to think like you have to be able to manage as a registrar. So how do you feel about managing the dialysis or CKD patient? 0 is like not so okay, and 10 is like I feel comfortable enough. 2, 3 responses. 3, 2, 4, right? Different ranges. Okay, we have got 23 responses. A majority is around 2 to 5. Oh, right, we've got 6. Good. Right, okay, around 2 to 3, 2, 3, 5. Okay, 2, 3, 4, 5. So let's start. Sodium zirconia is a new potassium binder. It's very effective, and you can start it when it's like a sachet. It's like a movie call. You dissolve it in the water and you give to the patient. The action of the sodium zirconia start within 1 hour, and you see the significant drop in potassium level within 4 to 6 hours. That is a lot better than our traditional calcium resonium, where the action tend to stop after 24 hours. And insulin dextrose is a good choice in the case of the emergency, but the action of insulin tend to drive the potassium into the cell, but once the effect wears off, the potassium can have a rebound. So we would like to know, what do you think? Oh, can you see the answer or no? Am I, have I,
Yeah,
you
we
can,
don't see the answer. We don't see the
you don't
answer.
see the correct answer, right? All right, okay.
Yeah, yeah, yeah.
Okay, I have got 20 responses. We have got 56, so approximately 50. I'm assuming that we can have more responses.
So we are
See the answer is the
actually,
third one.
Sorry?
We can see the answer is the third one.
Oh God. Right, I promise that's the only one that I take the answer to. Right, so 10 gram TDS 3 times a day, followed by 5 gram once a day. The question here is how long for 5 gram? We will talk about that in a bit. So correct one is 10 gram TDS, 3 times a day, 5 grams a day, followed by 5 gram once a day after that. What you have to make sure is we have a few incidents over the last year where the junior doctor prescribed the zirconium, but the nursing team did not manage to get the zirconium. So the patient never had the potassium binder and they ended up having the persistent hyperkalemia. That is very dangerous. So what you have to do is you tell the nurse to order it from pharmacy. If it is out of hour or if it is quicker, tell them to get it from Renal, E-Flow or F-Flow. We have it on stock all the time. So they can just give it to you. That is okay. And it's getting from the pharmacy out of hour is a pain, and you have to make sure patients have it. If not, they will bounce back with the hyperkalemia and it will be a nightmare, even though you prescribe it. So yeah, next one. What is your ideal potassium level to stop the zirconium? When do you want to stop? $5.5 is a big win. 4.5. Okay, so I've got half of the responses, 25 out of the 50, so I'll be relatively happy. So ideally, it depends on which ward you're on. I know for a fact that the cardiologists want to have the potassium to be more than 4. Is that right, Joseph, on your ward?
Yes, please. More than 4.5 if we
More
have
than 4.5, right? Okay. That is
if we
where
have a
the tricky bit
dyslipidemia,
is.
hypokalemic related. Yeah.
Yeah, but for me, if you ask me if it is less than 4.5, because if you stop it like 5.4, they have got higher chance of rebound. Well, not the rebound, because within like 24 to 48 hour, potassium will rise again, and normal level is 3.5 to 5.5, and you don't want it to be playing on the borderline. But if your bosses, the cardiologists say that they want it to be like a 4.8, you can just play with like a probably alternated day or like a small dose, 5 grams, and see how things are. And also, it depends on what type of the patient you are dealing with. If it is like a normal kidney function with the hyperkalemia, for whatever reason, you can adjust it. But if it is a CKD with a near hemodialysis patient, I would recommend you to continue it until they have got the proper plan from the renal, whether to dialyze or not. All right. Yes or no question. What do you think about long-term use of sodium zirconium? We talk about 10 gram TDS followed by 5 gram once a day. How long once a day? Yeah. Right? Quite divided. The correct answer is yes. So does it have to be CKD? No. We tend to give the potassium zirconium either 10 gram once a day for long term. In the people with the EGFR less than 15 or 20, they have got persistent hyperkalemia, even though they are adjusting from the diet. Or some people just don't care. You can tell them to have a low potassium diet. They'll be like, I don't care. I'm going to eat whatever I want, especially when they're diabetic, because they had enough of their life avoiding all the sugars in their life. So they want to have whatever they want. So if that is the case, you give a sodium zirconium long term. So what about hemodialysis patient? You might be thinking, don't they have the blood cleaning every other day? Why is it not effective? And some people know it doesn't. So they still have to take the additional sodium zirconium long term. We don't have the proper study regarding the sodium zirconium in renal yet because it is a relatively new drug. But so far, we haven't had any issue of the either CKD or sodium dialysis patient having the zirconium. Oh, that's my alarm. It's 10 minutes left. Oh dear, I should be quick. Next one. So I want to talk about the CKD and anemia and iron ingestion. So the reason why people with the CKD, especially people with EGFR less than 30, have got the low iron level is because of an accumulation of hormone called hepcidin. So hepcidin hormone is a peptide hormone that is released by the liver. The action is to reduce the intestinal absorption of the iron. In people with EGFR less than 30, there is accumulation of hepcidin hormone, so that consequently causes to reduce oral iron absorption in the intestine. That is why it is not effective to give the oral iron tablet in someone with EGFR less than 30. You should give the IV iron injection. It's a better way and more effective way. I have tried that in my patient with the EGFR less than 30. You give a 2-month supply of oral iron. Apart from making them constipated and blood pool, it doesn't make any difference. So better to have an IV iron injection. Right, let's do the quick voting. We have got 10 minutes to go, so. Is it not moving? So this is a 60-year-old with an EGFR, less EGFR 25, CKD4 patient with a chest sepsis. The question is, we can give the IV iron because he is anemic. The correct answer is the first option, actually, not the first option. I mean, like we need to complete the full course of oral antibiotics before you give the iron. So the study shows that IV iron during the episode of the sepsis impair the body's immunity and reduce the ability of a neutrophil to fight the bacteria. So it is not good to give an IV iron injection during the sepsis. So if you really need to correct the hemoglobin for whatever reason, so for example, if you're on the orthopedic works and someone needs a fracture neck or femur repair and he had got chest infection, and the orthopedic doctors say they want to increase the HB level to more than 90 or 100 before the operation, you just have to transfuse them. There is no way around to give the IV iron. And it will take longer as well because you need to rely on the bone marrow to make the RBC. So my answer was transfuse them. So complete the antibiotics and give the IV iron. And the other thing is, in addition to iron deficiency anemia, because of hepcidin hormone accumulation, they tend to have the low EPO level, erythropoietin level. Erythropoietin is a hormone that stimulates the bone marrow to make more RBC in our body. It is mainly produced by the liver and the kidneys. In the case of the CKD, liver tends to compensate, but it's not good enough. So in general, someone with the CKD, with the iron deficiency anemia, you have to give both EPO and iron. So now the next question is, what do you give first? Iron first or EPO first? No, it's quite comparable. So you have to give the iron first because EPO, think about it like iron as a raw material. EPO is a bone marrow stimulator. It's the factory. So if you don't have a raw material, bone marrow will not be able to make any RBC for you. And some people tend to get into extreme iron deficiency anemia if you give the EPO because the bone marrow start grabbing any iron available in the body to make whatever RBC that you want to create. So you have to give the iron first before you give an EPO. So what is the correct? Should be easy. That should be like bread and butter for you guys. What is the dose of dapivirine with EGFR less than 30? What should it be? Right. I'm just gonna be in a quicker pace. It should be 2,500. It never goes wrong. Even if a hemodialysis patient, even if they have got like a body weight of more than 100, you can always prescribe the 2,500. That is a safe bet. Anyone with EGFR less than 30, CKD, hemodialysis, dapivirine 2,500. Next one. Okay. And just a knowledge-based thingy. So how often do they normally dialyze hemodialysis patient? Ah, right. Yes, correct. 3 times a week. Oh, I'm too early. Yeah, it's 3 times a week hemodialysis, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, or Sunday, depending on how they are. Yes, some people do dialyze 4 times a week. And if they are higher risk of fluid overload, or if they are very non-compliant with the fluid restriction or diet. And the other option is there are some people who normally dialyze at home. They can dialyze up to 5 or 6 times a week, depending on how they can cope. So next one, the other thing I want to talk about is blood transfusion and hemodialysis. So anyone who is on hemodialysis, they should have the blood transfusion during the hemodialysis to avoid the blood fluid overload because 1 bag of the blood has got 250 ml. If you want to give two bags of them, that will be half a liter. Okay, what do you think? You have got the option. What is the correct approach if someone needs the blood transfusion during hemodialysis? GNS is group and safe, by the way. I'm sure you will know it. Right. So normal duration of hemodialysis lasts for 3.5 hours. So we need a cross match. But you can always argue that, well, you can just take the group and save or cross match at the start of dialysis, and why can't you just do it at the last hour of hemodialysis? In rare cases, yes. If your patient doesn't have any weird antibody or any special treatment that they need for the blood transfusion. So most of the time, you don't even need to do the cross match because they had like a history of the multiple blood transfusion over time. Sometimes the lab will be, well, it should be okay, but that's the rare cases. Ideal situation is if you need like a 2 units of blood to be done within 3.5 hours of dialysis, the best way is call the renal, call the lab, do the phone, and inform us so that we can sort it out. In the worst case scenario, for whatever reason, if you're too busy to do that, you can always call and let us know. But sometimes we can squeeze in 1 unit at least because we can do the cross match at the start. And then if the lab do everything very quickly, we can have it in like 2 hours into dialysis and we can transfuse them. But that is not the ideal situation. And we don't like that, especially our hemodialysis nurses, they hate it. Right, next one. We're not keen to transfuse the young hemodialysis patient. Why is that? Majority of you guys are correct, actually. It's especially regarding the transplant. But if he is bleeding left, right, and center, don't think about it. Just transfuse him. He's going to die if you don't transfuse. So yes, you might want to be cautious. Let's say HB is 75, and if you're contemplating in 30-year-old man whether to dialyze or not. So think about it before go ahead and transfuse. Next one. So CT scan and hemodialysis patient. What do you think? Right. So ideally, we should do the HG within 12 hours of contrast, but in the NHS, we compromise with 24 hours. The main reason is to reserve the residual kidney function. You might know some of our hemodialysis patients, they still weak. It means that they have got some capacity of EGFR, let's say like 3 or 4. A study shows that the retaining that residual kidney function is good for the survival. So for example, people who can weigh like a liter of urine output, even though they are on hemodialysis, they have got the higher survival rate in general compared to who doesn't weigh at all, completely anuric. Again, that's my alarm for 3 o'clock. Sorry, we are getting there. And yes, we want to get rid of the contrast to maintain the residual kidney function. Okay, so someone with the EGFR 14, they are not on dialysis. They need a CTPA with a contrast for the query PE. Does he need hemodialysis? Yeah, the answer is no, most of the time. So what the contrast-induced nephropathy tend to be more prominent within 48 to 72 hours after contrast. So if somebody is having the contrast, all you have to do is give a pre and post 1 liter before 1 liter after IV infusion if they are not fluid overloaded, and you monitor the kidney function. Let's say if you're on SDAC, you have got someone with EGFR 14, they come in for the query PE, you have to arrange the CTPA, you have to give a pre-contrast IV fluid, post-contrast IV fluid, and what I would ideally do is tell the patient to drink plenty when they get home, come back to the SDEC 2 to 3 days later to recheck the kidney function. That's what I would do. It's easier if the patient is inpatient. You can just do the daily blood check after that. Right, that is for the CKD follow-up. Let's say like you're happy that kidney function is stuck around creatinine on 300. Nothing has changed. He finished antibiotics for his community-acquired pneumonia. What would you do? You want to make sure. Well, all three are correct, actually, because whatever you do, we will end up writing the email address to you guys. So I put it here. That's the email address. So if you want someone to be follow up for like either AKI or any suspected kidney follow up, if it is a new patient, it's a different email. It's known to us, it's a different email. And take a screenshot of that. That will be very helpful. And then you can just send it out. Those emails are normally read by our consultant for all the filtering and to decide when they would need to be follow up. You don't need to request how long or when you want them to be follow up. We just read the email and we decide whether 2 weeks or 3 weeks or 6 weeks. Okay, that's it. That's the end of the section. Okay.